Okay, so working our way through the system yesterday, I ended with the line pressure gauge, which again, somewhere near your oxygen source. Now, for you guys, that'll be the tanks on the anesthetic machine. You'll have your oxygen pressure gauge and the pressure in your tank, pressure reducing valve, line pressure gauge, which should never be above 50 psi. And then that line, if you trace it, because this is all about tracing the flow, that line is now going to go into your flow meter. And I don't know why my slide looks so weird here. Apologize for that. So when the oxygen goes from the source into, you'll see it comes into the back of the flow meter. And the flow meter, now this is measured in liters per minute, not in PSI. You're going to turn on the flow of oxygen. And this is the part of the machine. It does further reduce the pressure. The maximum pressure that can come from the flow meter is 15 PSI. Now, there's no gauge that measures that. So you won't see a gauge that says 15 PSI. It's just when it comes to the back of the flow meter, it's regulating the flow from there to the machine. But when you turn it on, when you guys calculate oxygen flow for your patient, you guys will get like a surgery packet that will tell you how to set your calculations for your patient. You're going to calculate it in liters. And there is a specific flow meter for every type of gas. And we control that flow. So let me show you the picture because it's easier. So this right picture here, for example, the one on the right, because it's green, that is actually an oxygen flow meter. And then nitrous oxide is blue. And so this one is a blue, that is the nitrous oxide flow meter. Now, a few machines that I had at Purdue, they actually, they were equipped to run oxygen and nitrous now. And so, but you have to set the flow per flow meter. I don't know if you remember when I was talking about nitrous oxide, I gave you an example is I never run nitrous by itself. It's an adjunct. And if I needed 1 liter of flow, I might do 800 mils of oxygen, which here's a little bit of math, it's 0.8 liters. And then I'd run 0.2 liters of nitrous, which would equal a total flow of 1 liter. So when we ran nitrous, we usually mixed it in with the oxygen and anesthetic. So the total flow going to the patient would have been 1 liter, but you would have to set them on the separate flow meters. And they're usually color coded so that you know which one goes to which gas. So in this picture right here, that's just an example. You've got an oxygen flow meter, you have a nitrous flow meter. And then this one, you can see the dial is green. So, and again, there's a dial here and you would turn it righty-tighty, turns it off, lefty-loosey. This is a dial for sure you need to not tighten too hard. Inside this dial, there is a little pin, and that's where the oxygen comes out. And over time, you can damage that pin if you turn this off. Usually when you turn it off, I don't know if you can see, this is a ball, and this is a bobbin. When you turn it on, when the oxygen comes in, that's going to float because this tube, there's a clear tube in here. And so as you turn the oxygen up or down, you can move that either bobbin or ball. Now, if you use a ball, I'm just going to tell you, you want the ball to be at if you want it to be at, say, 2 liters, you want the middle of the ball at 2 liters. If you're using a bobbin like this, you want the top of the bobbin at 2 liters, and that's how you set the flow. And so it kind of just depends on the flow meter you have. And this is what I was talking about. If you say you had a tank that was really low, an oxygen tank, I was talking about like your gas tank, and you're kind of pushing it, you're going to try to run. As long as that bobbin is floating, you do have oxygen. What you'll notice if you run out of oxygen is when it's on, that ball or bobbin will start to fall. And that means you're running out of oxygen, and then you have to switch your oxygen tank. So if you're the anesthetist, periodically, you just need to look at your flow meter and make sure that the bobbin is still on or still moving. And also, you're going to be watching your rebreathing bag. If you have oxygen, usually your rebreathing bag will have gas in it. If your bag was to start to go flat, that's when you have to be careful. Did we run out of oxygen? Did something get unhooked? But you want to set the flow, and you just do it by turning the knob to the left, and that's what opens the oxygen. And then you just set your determined level. Now, again, if you're using an anesthetic machine just to deliver oxygen, as long as your vaporizer is turned off, the oxygen will go through the vaporizer, but it won't pick up anesthetic. So you can use an anesthetic machine to deliver pure oxygen, like I said, when they're waking up, or sometimes we pre-oxygenate, or, on emergency, so an animal may come in and need oxygen, and you need to give oxygen. And so you can use the machine to deliver the oxygen flow. But I want you to know the flow meter is set in liters per minute, and that's how we determine the flow. Now, on a machine, and when I have you guys in person, I turn around the machine and I show this to you. When oxygen comes from the tank, there's a split. So it'll come into the flow meter, and there's a little tube, and it goes up to somewhere on the machine. It's in different locations on different machines, but there's a button, and it is called a flush valve. And a flush valve will give a burst of pure oxygen into the breathing circuit. But the big important thing about the flush valve, it bypasses the vaporizer. So the tubing, when you hit that button, it does not go through the vaporizer. It goes around the vaporizer, and it goes directly into the breathing circuit. So if you have to give a burst of pure oxygen, you can do this without delivering anesthetic to the patient. And it bypasses the vaporizer, it bypasses the flow meter. Now, what's interesting is when you hit the flush valve, it can deliver up to 75 liters in a minute. Like if you held it for 1 minute, you could deliver 75 liters of oxygen. So it's very high pressure, it's a very large amount of oxygen very quickly. I never, ever sit there and hold the button. Usually when I do the flush valve, I do psh, psh, psh. I do little like quick pushes to kind of deliver bursts, because you can deliver a large amount. You're delivering it right into the breathing system, to the lungs. So especially if you have a little patient, you have a small patient, you have to be very careful, because you can deliver a large amount of pressure and you don't want to cause any damage to the lungs. Now, there's rules on, and this is, a lot of people in clinics, you might work with people that are maybe assistants that have been on the job trained, or they've just worked there forever. And a lot of people, sometimes during anesthesia, an animal starts getting light and they start breathing really heavy, and they start breathing so much from the bag starts to go flat because they're and some people want a panic bag. I call it panic bagging, because the patient's getting light, so they start squeezing the bag, but the bag isn't full. So they hit the flush valve, because the flush valve will blow up your bag very quickly. But the problem is you are filling the bag with pure oxygen. And if you have a patient that's getting light, every time you hit that flush valve, you're diluting out your anesthetic. So if you're trying to make the patient deeper, you're actually doing the opposite. Every time you hit the flush valve, you're diluting anesthetic, and you're actually going to make them lighter. Even if you turn up the vaporizer and you hit the flush valve, the flush valve goes around the vaporizer. So you just keep delivering pure. Now, when I want to wake a patient up, first of all, I can use the flush valve if I want to get a patient awake. So first of all, if you want to wake the patient up at the end of a procedure and you want to dilute out your anesthetic, you can hit the flush valve, and that'll fill your bag with pure oxygen. and that'll make them lighter. If I'm doing CPR, if we have an arrest and I have to dilute out anesthetic, I can hit the flush valve. When I check my machine in the morning and I want to fill it up you have to pressurize the system when you check it, I'll hit the flush valve. But I never use the flush valve when I have a patient under anesthesia during a procedure. And that's a rule that you need to know. Because again, if what you do, and this is important, when you want to fill your bag during a procedure because they're breathing too deeply, all I do is I turn up my flow meter. If you turn up your flow meter is running oxygen through the vaporizer. So then you're adding oxygen and inhalant. So let me give you an example. The average patient gets 1 liter of oxygen during anesthesia, and that's usually adequate to keep everything full and adequate for the patient. But if they're getting light, sometimes I'll go up to 4 or 5 liters. I mean, I'll crank the flow meter. You'll hear it go, you'll hear oxygen. Your bag will start to get full. When it's full, I'll turn it back down to my 1 liter, and then I can bag my patient. So during a procedure, in the middle of surgery, the best way to fill your bag is to use your flow meter. So that way you're running anesthetic. The flush valve, like I said, waking up a patient during an emergency or checking your machine like in the morning. And I never use a flush valve patients under 15 pounds, which I'm going to talk about a non-rebreathing system because you don't want to blow up their lungs. So I don't use it for small patients because you just have to be careful. There's something called barotrauma, and barotrauma is if you overbag a patient or you were to hit that flush valve and it kind of blows up little alveoli in the lungs, and then you can cause damage to the lungs, and that's not what we want to do. So you have to be careful of pressure, and your flush valve, like I said, it's great in an emergency and it's great for checking the machine, but not to fill your bag during a procedure. And again, a lot of people, that is fast. A lot of people are tempted to do that, but they're working against themselves. You're just going to wake them up. So the other reason I use the flush valve is when you turn off the machine. So like in this picture, when you turn off your tank, remember I said your line will hold pressure. So your tank won't go to 0 when you turn it off. Your oxygen tank won't go to 0. When I turn it off, you can hit the flush valve and you hear psh, and it'll bleed all that oxygen from the tank. So that's the other time you can use it. Make sure you do only short bursts, and you never want to hit it where your bag gets too full. If you have a rebreathing bag that's really stretched out, that's putting excess pressure in the system, and you don't want to do that. So short bursts, if you fill a collapsed bag, it does not contain anesthetic. So just like I said, the only time you use it is when you want to dilute the anesthetic at the end of a procedure. And again, if you're delivering oxygen and your vaporizer's off, you can use it to, fill your bag. Sometimes what I do at the end of, like, if Dr. Ritz says she's like doing the last couple stitches and we know we want to wake the patient up, sometimes I'll squeeze my rebreathing bag out completely and I'll get out all that anesthetic that's in the bag. And then I can hit the flush valve to fill it with oxygen, but that's because we're done. So sometimes what I'll do is I'll empty the bag, hit the flush valve a few times, fill it, give my patient a breath of oxygen, hit it, give my patient a breath of oxygen, and then I'm diluting out my patient and I can wake them up easily. So again, short bursts, because again, we want to do this very quickly, short bursts. So does anyone have any questions? And I never use it with a non-rebreathing system. Let me make a comment, and it's going to be a while before you're on externship, but the machines at school, if you have a non-rebreathing system hooked up, it actually doesn't allow you to use the non-rebreathing system. The way you hook up a non-rebreather, and see, non-rebreathers are for 15 pounds and under. So some machines, when you hook up a non-rebreathing, you can't use the flush valve because of the way it's hooked up. But I've seen some different machines, the way, because, you know, all machines are different a little bit. I mean, they have all the same parts. There's just a little bit different design. Some machines, you can use the non-rebreathing system or the flush valve with a non-rebreather. So I just always tell students, when you go to externship your very first day, just make sure you get used to the machine, maybe hook it up, you know, and not on a patient, and make sure you're familiar with how it works. I just, like I said, I wouldn't want to go in cold turkey. You know, you guys are kind of spoiled at school because we have nice newer machines and things are labeled and things are set up. And then you go to your externship and they've got this machine from like 1970 and it looks completely different. And, you know, and again, they have all the same parts. It's just you need to get familiar with how that machine works. So I will say you have to kind of make sure how that works. I've already kind of gone over vaporizers, so hopefully everyone remembers the, you know, basically they vaporize liquid into, you know, they turn the liquid anesthetic to a vapor. Oxygen carries it. And if you look, now that we've kind of talked about the machine, your flow meter would be like over here. It's not in the picture. It would come into, when you turn on your flow, it comes into letter A, which is the inlet. If this is turned on, which in this machine, it looks like it's at the 2%. Now vaporizers, there will be a few questions on the test about vaporizers, just to review. But remember, if you have a vaporizer on, 2 means 2%. So that's what so 1 liter flow goes in to the vaporizer and delivers 2% isoflurane or whatever. And then when it comes out the outlet at letter B, now you have a mixed gas. You have oxygen and inhalant. Letter A, only oxygen. Letter B, oxygen and inhalant. And then you've got your fill window here. You have your port where you fill the liquid anesthetic. And that vaporizer in that picture is the precision vaporizer. So it's temperature controlled. You can control the percent, a precise amount, because, does anyone remember what type of anesthetics, low pressure or high pressure, high vapor pressure anesthetics, which one uses which? I'm making you dig in your brain a little bit.
Is non-precision for low?
Yes, yes, because remember, low pressure or low vapor pressure anesthetics don't want to turn to a vapor as readily, so you can use a non-precision because they don't vaporize as readily. The new agents, which is ISO and SIBO, are high vapor pressure anesthetics, and so they are kind of volatile. Yes. So, yep, what Emily wrote there. So, yes, so precision vaporizers are used to deliver high vapor pressure anesthetics, which is what we use today. And remember, because I said if you put ISO on a cotton ball, you can deliver 30% isoflurane, like if you put it in a cone on their face. So because it wants to vaporize so readily, you need a precision vaporizer. And part of that is also temperature controlled. And so again, this is the difference. And this is the jar and wick kind, and then you have like a little valve up here that you opened and closed to kind of like, and you would just have to monitor your patient, monitor their muscle tone, jaw tone, vitals, and you can kind of turn that valve up or down. But remember, the other difference is this vaporizer, which was non-precise, was in the circuit. So when the animal breathes, they pull oxygen through that vaporizer. So if they increase their respiratory rate, they're breathing more, technically more anesthetic. And this vaporizer is out of the circuit. So when you set the vaporizer, it's going to deliver 2% no matter what they breathe. 5 times a minute, 40 times a minute, whatever. It doesn't affect the concentration that the patient gets because it's precise and it's out of the circuit. So the two terms that you just remember is a VOC, out of circuit, is a precision vaporizer, and it's used, you set the flow of the oxygen goes through the vaporizer to the circuit. When you have in circuit, you turn on the flow meter, it's going to go to the patient, but they're going to be breathing through the circuit, so they're going to be they're going to be circulating the gas through the vaporizer. That's why it's non-precise, and those are the differences. And the output, the vaporizer setting in a precision vaporizer, it's set, number one, by temperature, number two, by your oxygen flow rate, and then you set your percent. And that is consistent. That will not change with a precision vaporizer because it's not affected. So really it's the in circuit that can be affected by temperature, more by respiratory rate. And
I have a question about that whole temp thing.
yes.
Is there like a heating element or something? I mean, how is
Yes.
the temperature controlled?
Yes, they're inside, even though it's like not plugged into anything. There is, because it's like insulated. I don't know what to be honest, I'd love to see the inside of a vaporizer. I've never seen the inside of a vaporizer. But inside the parts and the insulation, it does keep it at a more consistent temperature. So I think it's more like insulated, not that there's necessarily a heating element, because yeah, it's not plugged into anything that would, keep the heat going.
Right. So we never ever mess with temp. It's just an automatic thing with it. It does what it needs to do.
Yes, I do know, like, so there was a Facebook post in my anesthesia group that I belong to, that my friend's hospital, the OR did get super cold, and it did affect the constant. They had to send the vaporizer off, but when they tested the temperature in the room, so it's not that it's completely impervious to temperature, but it has a better insulation to keep that at a consistent temperature, if that makes sense.
It does. Thanks. I was just trying to figure out how the temperature is regulated and if we need to worry about it at all.
Yeah, if the problem that happened, and if you're in a practice, what happened at my friend's clinic was they realized these patients were really light, like procedure after procedure. They were having a hard time keeping these patients anesthetized, because normally my friend was like, I can keep them between 1% and 2%. I normally don't have these problems. They were having to turn them up. And when the company came out and they tested the vaporizer, I think it was a little colder. And what was happening is at the percents they were setting, it wasn't delivering what it said it was, but it was also being affected by the room. They were like, your OR is super cold. And she goes, yeah, I've been more cold. I made a comment. I go, how are you working in an OR that was that cold? I mean, I would have said something like, an OR is always going to be cold. Your OR is always supposed to be colder than the rest of your hospital, because of people in gowns and also for bacterial growth. So you never really want to turn up the heat in an OR. You just have to realize you're going to be cold. If you're the anesthetist, now the gowned people are like, oh, it feels great. But, it was actually lower than it was supposed to be. And then they sent off the vaporizer and had it kind of serviced. So if you were in a clinic and you realized you were having a hard time keeping patients asleep, when you're used to setting a normal, percentage, that kind of clued them to have the company come out and service it. So occasionally it does have to be checked and serviced, yeah. So really it should be fairly temperature controlled, and the respiratory rate it only affects the non-precision vaporizer. So respiratory rate doesn't affect the output of a precision vaporizer, because again, they're not breathing through it. So I've talked about the percentages. Don't worry, the percentages and what you put your patient on are not on this test. Only like maybe what's the difference between the two, and the kind of the main things I've stressed about the actual vaporizer. And keeping it full, make sure you check it before your procedure. And all you do is do that by looking at this window. Now, it said in there, keep it half full. I mean, you guys will probably fill it unless it's up to the full. You don't want to overfill it because then it can backflow into the vaporizer. So you really don't want to go past the full line. If it's right above the line, you just have to kind of watch. If it's, but I would just know, as if I'm an anesthetist, I'm just going to fill it before I start the procedure. That's one of the things you guys have to check. And then make sure that it doesn't get tipped. And when you fill it, we usually fill it in the OR. If you spill, I would leave the room. We'll close the vaporizer and make sure you're not like standing over the spill for a long period of time, because again, it's going to vaporize quickly. You could literally pass out. I've seen people get woozy, stumbly. So again, it's best if it spills, is try and leave the room or try to air it out, maybe a fan. ROR at school doesn't have a window. Some vet clinics in surgery, you literally have a window, open the window, get air circulating, put a fan, things like that, just to make sure you're not standing over the spill. And I talked about the outlet of the vaporizer, so we've kind of talked about so let me talk about breathing circuits. Does anyone have any other questions about the vaporizer?
I'm good, thank you.
Okay, good. So the breathing circuit is what we hook up to the anesthetic machine to the patient. So the circuit is what carries the gas to the patient, and then it allows a tubing to remove exhaled gases from the patient. So that's when we talk about the circle, is the gases are kind of moving in a circle. And the two types of systems are rebreathing systems and non-rebreathing systems. And those are the two types of the systems that we have. And let me talk about the rebreathe. And rebreathing literally means exactly what it says. In a rebreathing system, an animal is going to rebreathe their exhaled gases. It's like going to recirculate. And so people also call rebreathing systems circle systems, because the gas is essentially moving in a circle. So if someone says, hey, let's go I'm going to hook up a circle system. I mean, I call them rebreathing systems. Most people call them rebreathing systems, but they're also called circle systems. And they are going to be used for patients 15 pounds and up. So if they're 15 pounds or more, they are going to be put on a rebreathing system. The difference is, and I think I've showed you on, let me see if where's the picture? Okay, let me show you on this picture. This top part is a non-rebreathing system. I'll go over that in a little bit, but the bottom here is when it goes out the vaporizer, it's going to come to the inhalation valve. This is fresh. Right now, we're talking about fresh gas and anesthetic. The Y piece part here, this is the patient connector, hooks up to the ET tube. So where this red arrow is, your endotracheal tube, and then your patient would be here. So they inhale, and when they exhale, they're exhaling CO2, but they're also exhaling some of the gases they haven't used. So it's oxygen, inhalant, and CO2. And when it goes out the exhalation tube, out this valve, it's going to go through the soda sorb, soda lime, CO2 canister. People call it different things. I talk about soda lime. When it goes through the CO2 soda lime, it removes the CO2 from those exhaled gases. And then those gases, do you see there's like a two-way street here? It can make a right or a left. When they exhale, some is going to go into that bag, because when an animal exhales, you'll see your bag expand. Every time they exhale, it expands, and every time they inhale, it goes in, because they're breathing. Some of that gas is going to go out here, which is called your scavenge system. In the OR, you guys may have seen there's like a blue hose that goes up into the ceiling. There's a pipe. Because at school we have an active scavenge. So we have a suction scavenge that will actually pull that gas as they exhale. And again, like I said, some clinics use what's called an F-air canister. In the prep room, the dental station, it's a charcoal filter, and when they exhale, it goes into that filter, and that filter absorbs the anesthetic. And so that you don't, what I don't like to see, and I'm sure at least one of you may experience it, sometimes people just lay that hose on the floor. And it's just going into the air that you're breathing. So I don't like that. It should be, at minimum, maybe my old clinic back in Chicago, we had a pipe that went out the wall, and then the pipe went outside. So I'd hook it up there, and that's called a passive scavenge, where it goes as the air blows, it pulls air. So on a windy day, it pulled more. On a not windy day, not so much. But the important part is that when an animal inhales, again, in a rebreathing system, they're pulling from this bag, so they're using recycled gases, but they're also getting a constant fresh flow. So it's a mixture. It's getting some fresh oxygen anesthetic and some recycled oxygen anesthetic. But that's why it's key to make sure your soda lime is fresh, because this doesn't last forever. So I'll get to that part here in a minute. Let me go back here. Whoops, too far. Okay, so the airflow, the vaporizer, at the outlet of the vaporizer, remember I said it connects to the breathing circuit, but it has to go through the inhalation valve, and that's called a unidirectional valve, and that's what it means, unidirection. When an animal inhales, that valve is going to open, and then oxygen anesthetic go through the tubing, inhalation tube, to the animal. And then when they exhale, it goes out the exhalation tube, and the exhalation valve opens. And that allows the gas to come out. It has to go through the carbon dioxide. And then it goes past, some in the reservoir bag, some out the pop-off. And usually somewhere right here is the pressure manometer. And I'm going to talk about all these parts, don't worry. And then it goes back to the unidirectional valve. So this is our circle system. The one that you guys are going to be using, don't worry about a closed rebreathing system. This is very rarely used. You guys are going to do what's called a semi-closed rebreathing system, because your pop-off valve is open, but you can close it at times. So that's why it's called semi-closed. I literally don't leave it semi-closed. It's either all the way open or it's all the way closed. It should always be in the open position. The only time that you close that pop-off valve is when you go to give them a breath. Other than that, it should be open. And so the patient can, because if you close a pop-off valve, it traps, then your flow is trapped within the breathing system and the patient, or in the machine, the system, and the patient. And then the problem is you're delivering fresh gas, so you're going to constantly increase the pressure. That's why one anesthetic death that can happen is if you leave the pop-off closed, and it can blow up the lungs or it can stop the heart. So the pop-off valve, it's very critical. The valves that we have at school are nice. It's a little button that you guys push, and you just push the button and you squeeze the bag, and then when you let it go, it opens. So it's like a safety mechanism. The other pop-off valves are like a dial you have to close, and then you have to open it up again. So during anesthesia, it should be open. That's called a semi-closed rebreathing system. Pop-off is open and your oxygen flow is high, usually around 1 liter, somewhere around there. And then the excess gas goes out the scavenge system. And that's the most common. There is closed flow, closed low flow. But again, that's more of a special technique. I want to just focus on the main, what you're going to be doing daily. So I've already explained this. The rebreathing system, these are all the parts. Now, these are not the parts of the actual breathing system. The breathing system is just the tubing. These are all the parts of the machine that you use with a rebreathing system. So this is an important slide because I want you to be able to trace the flow. Just like I talk about tracing the flow of a red blood cell through the heart, tracing the flow of an oxygen molecule from the oxygen tank to the patient all the way when they exhale. That's how we should trace the flow through an anesthetic machine. So it's very similar, except instead of anatomical parts, I'm talking about machine parts. So same principle. So this is an important slide that can kind of tell you what you need to know along the way. If we look at this picture, then we've got a rebreathing system here. This is, so letter A, this is actually, you've got the inhalation valve. That's the unidirectional valve. Goes to the patient. When they exhale, comes out through letter C, which is the exhalation valve. And letter B here, this is your pop-off valve. So this has a dial, and it always needs to be open. Letter D here, that's that pressure manometer, and that's going to tell you what is the pressure in the breathing system and, you know, between the patient and the machine and the system, what is the pressure? And again, when an animal is on a machine, and I'm going to talk about that pressure manometer, but because I'm looking at it, normally there's no pressure in the system. It should be zero. So when a patient's breathing on their own, it's zero. The only time that that shows pressure, when you go to give the animal a breath and you close this pop-off valve up here, when you squeeze the bag, you'll see that pressure increase because now you've closed the pop-off. All the pressure is in the system and the patient. And you only want to go up to 20 centimeters of water. But when you open the pop-off, that should relieve all the pressure. It should go back to zero. So periodically you should peek at that manometer, but if your bag is not over full, you probably don't have pressure in the system. So as long as my bag's not like huge, I probably don't have an issue. Let me talk about one part and then I'll go back to the types of breathing systems. The unidirectional valves, these are very important. And so they're called unidirectional valves. One is called the inspiratory valve and one is called the expiratory valve. And literally, let me show you this picture. These are called domes and they're usually clear. And what's interesting, on some machines, well, most machines, they're clear. When an animal inhales, one will open, and when they exhale, the other one will open. Okay? So this is so they don't mix up the gases. Okay, so this ensures that the animal is not inhaling some of those exhaled gases. And now they are going to recycle their gases, but they have to go through the soda lime first and go to the bag. If the unidirectional valves weren't working, what happens sometimes is if the animal exhales, they will get those gases right back and are going to potentially rebreathe CO2. So we don't want that. So the unidirectional valves, if I ask you, you know what this means. If I ask you what controls the flow through the anesthetic machine, the flow of anesthetic gases, it is the unidirectional valves. It is not the patient and it is not the tubing. It is the unidirectional valves. And what's interesting is some of the machines, when an animal is breathing rapidly, you'll hear ding, 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 ding. If an animal is going ding, 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 you can sometimes use it to count a respiratory rate because you can hear, or sometimes I'm doing anesthesia and I'm talking to the surgeon and maybe I'm not like looking right at the patient and all of a sudden the patient feels something and they start going. Sometimes the first thing I hear are the unidirectional valves moving rapidly. Some of the machines at school, they're plastic in a plastic dome, and so you don't hear them. But in some machines, there's like a metal part in there and you can hear them move. So if all of a sudden I hear ding, 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 and then all of a sudden it stops, I'm like, wait a minute, the valve stopped. My patient stopped breathing. I mean, and sometimes they do that. Not saying that they died. They're just, sometimes they breathe rapidly. They get rid of their CO2, they stop breathing a minute. CO2 goes back up, they start breathing rapidly. So what's interesting is that you can kind of use them for monitoring. If you hear it, you can kind of go ding, 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 1, 2, 3, 4, and you can do that. But that's why they're important. They open and close when the patient inhales and exhales, and you can monitor the respiratory rate and the depth. Because like I said, when an animal starts breathing very deep, they're going to move those valves more, and they are sometimes going to make a louder sound. So again, it is a way to monitor breathing in our patient. But it is very important that those valves, and some patients don't move them as much. You know, this is another thing too. It says there's a note under the gray box. They may be also used to check for proper placement of the ET tube. There's been some times where someone went to intubate, and I've seen this happen, and it goes in the esophagus. And then all of a sudden you see the patient breathing, okay? But the unidirectional valves are not moving. That means your tube is in the wrong place, if it makes sense. Because if an animal is breathing in and out, number one, your bag should be moving. Number two, your valves should be moving. If you're not getting rebreathing bag movement, if you're not getting fogging in the endotracheal tube, or if your valves are not moving, you've put the tube in. And there's been there's been times I've been fooled. Sometimes an animal, they're very deep back there in their throat, and sometimes I go to pass it and I'm like, oh, I'm in. And sometimes it might slip off the side and it's hard to see. Now, when I talk about canine feline anesthesia, I talk about intubation more in depth. There's other ways to check your tube placement. But one thing is using your equipment to, you know, again, if the patient's chest is moving and your valves are not, something's wrong. And probably what you need to do is pull that tube and put it back in. So you can, you know, it's kind of a nice thing to use. I need to talk about the pop-off valve and show you it a little more. And okay, but I'm going to stop there. Do you have any questions based on what we just saw? Okay, so the question is on the diagram for question number 1 on the homework is when you're tracing the flow, this is, remember I said, when the oxygen comes to the back of the machine, it's going to go to the flow meter, and then there's a splitter. This is the flush valve. So
Okay.
this is telling you that when you hit that flush valve, it's not going through the vaporizer. There's a pipe or tubing, depending on the machine, that goes from that oxygen line, and it goes directly into the circuit. So when you hit so it's on, if you were doing the flow for that question number 1, you almost have to do like a split, because
Yeah, that's where I was getting confused. I was like, I'm not sure where that fits in.
as long as you put the flush valve after or like right before or after the flow meter, and
Okay.
just know, you almost kind of have to just kind of put that to the side, and that's fine if you do that on the homework. I just want you to know the main thing is that the flush valve, the connection is set up so that it does not make the button, the flow goes around the vaporizer. And so on
Got
the
it.
drawing, it looks like it's way out here. In theory, when you look at a machine, when you turn around the back of the machine, if you follow the oxygen tube, you'll see a split. And one is in the back of the flow meter, and the other one kind of goes up and around, and then it goes to the breathing system so you can give that fresh gas.
Okay, I just wasn't sure where to put that in, so thank you for that.
Well, that's a good question because it does on a schematic or when you're doing things in order, as long as you could just kind of put like a little side note, like flush valve here. And as long as everybody understands that when you hit that, it won't go through the vaporizer. It's just going to be separate outside. Yeah.
Gotcha. That was my only question.
Okay, cool. No, thank you for asking that. So, okay. Any other questions regarding that or something? Okay.